I think we can start our session, Dr. David. All right. Thank you so very much, Dr. David, for coming online and joining us for this online lecture series. I'm really grateful to you. And for the participants, I welcome all of you. We are starting the session, and before starting the session, I would like to introduce Dr. David Pilcher, who is the president of ANZIC, which is the vice president of ANZIC, which is the Australian and the New Zealand Intensive Care Society. He's also the senior intensive care specialist at Alfred Health Brahan, if I'm not pronouncing it wrong, in Australia. He's also the chair NZIC Center for Outcome and Resource Evaluation and adjunct clinical professor at Monash University. Thank you so very much, Dr. David, for joining us. We welcome you from the Pakistan Society of Anesthesiologists. Dr. David Pilcher had recently visited Pakistan back in last month in February, and he was our guest of honor as well. So we are also thankful for him for his overall support. Dr. David, you can continue. Thank you so much.
Thank you very much for that kind introduction. I'll just start my slides. Just give me a second. And as you said, I had a really nice time in Pakistan just recently. It was really interesting for me. It was the first time I'd ever been to Pakistan. I've had lots of contact with people who have worked in Pakistan or from Pakistan, and it also gave me the opportunity to catch up with old friends who I'd worked with in England before I came to Australia. It was great to meet up with them again, so over 20 years later. So as I was introduced, I am an intensive care specialist from Melbourne in Australia. I trained originally in the UK and spent time doing general medicine and respiratory medicine, and then doing anesthesia, and then came back and finished respiratory medicine before coming to Australia and taking up an intensive care fellowship. I originally came for 1 year, and 1 year was 24 years ago. So, and became quite early on, became quite involved with the intensive care registry, who are the group who collect data from all of the different intensive cares around Australia and New Zealand. And there has been a long tradition in the two countries of collaborating very closely and having a single training scheme for intensive care that accepts people from multiple different specialities and trains them in all aspects of intensive care: general intensive care, surgical intensive care, neurosurgery, cardiothoracics. And a part of that work has been, part of that, the focus of that group has been the need to compare the outcomes for different hospitals and for different ICUs, because although we have a fairly consistent intensive care system, we have a wide variation in the type of ICUs that we have and the type of areas that we have to deal with, from dense metropolitan areas in high tech, well-resourced centres in Melbourne and Sydney, and at the opposite end of the spectrum, sort of centres in the areas in the centre of Australia, which provide intensive care services to a vast geographic area with very low population density. So mortality prediction for us has been important. So what I'm going to talk to you about over the next sort of half an hour or so is what I mean by mortality prediction and severity scoring systems, severity of illness scores, a lot of what these sort of concepts mean. Differentiating between scores and risk prediction. I am going to bring in a little bit of sort of some of the concepts that underlie prediction models. So discrimination, calibration, and validation. I am not going to talk about statistics though. And what I will do though is give some degree of a story about our experience in Australia and New Zealand with using prediction models that had been developed elsewhere in the world, and also developing our own models, and talk a little bit about uses and pitfalls of these type of models, and what I think might be coming in the future. So, models. When we're talking modelings, a friend of mine gave me this sort of slide that he likes making model aeroplanes. He said there are other types of models. The type of models that we're talking about are mathematical models, but there are some similarities between all of them. And sometimes the models don't behave as you want them to, or cannot be as predictive as you want them to be. And those are some of the aspects that I'll hope to bring out as we're talking through the relevance of using this type of information for examining the outcomes of intensive care patients in particular. There are many other sort of prediction models, many other scoring systems that are relevant to anesthesia practice, for instance, to cardiothoracic practice, POSSUM scores, Euro scores. I'm going to concentrate predominantly on the intensive care practice because that's where my area of experience is. But the principles exist. The principles are applicable to a wide variety of different situations. And essentially, we're talking about there's two concepts, two phrases that get used interchangeably to some degree, but it's useful to differentiate them. So we have scores and risk predictions. A risk prediction here is allocating a predicted risk of an event, and in this case, mortality, to a patient on the basis of their characteristics. A score is an arbitrary value, an arbitrary number, potentially based on the same characteristics, where typically high scores indicate a higher risk of death, but the score itself doesn't tell you what the risk of death is. Critical care practice has a variety of different scoring systems that are in use. They vary around the world, and they vary in their applicability and the situations in which they're typically used. Apache and SAPS have both scores and risk predictions. Apache 2 is probably the most well-known and most familiar to, I think, clinicians around the world. And Apache 2 score of 15 or above indicates a moderately sick patient, but an Apache 2 score of 15 in the 1990s would have indicated a patient with who's got a potentially 20 to 30% risk of death. An Apache score of 15 in the modern era, at least in Australia and New Zealand, would indicate a patient who's got a less than 10% risk of death. So they have slightly different, they're slightly different things, but they overlap. Apache and SAPS, as I say, can create both a score and a predicted risk of death. MPN, mortality prediction models, and ANSROD, which is our Australian and New Zealand risk of death model, just purely give you a risk of death for a patient. And then there are other well-known scores, such as the SOFA score, which goes from 0 to 24, where higher scores indicate greater degrees of organ dysfunction. And this group may or may not be aware that there is a European-based group who are working on a new version of the SOFA score right at the moment, which, if everything goes to plan, will probably come out later towards the end of this year. But that's in the process of being developed right now. And together, they're what we call scoring systems, but they're all really developed in the same way. So they all take some patient characteristic, either a demographic characteristic or a physiological or biochemical characteristic, or some other sort of piece of information such as a diagnosis, and ascribe a mortality risk or a score based on that value. On the left, you can see here, this is the mortality with increasing age for patients admitted to Australian and New Zealand ICUs over the last approximately 10 years. There's over 2 million patients that have gone into these figures. So they're consistent, but there's obviously a fair bit of variability. And obviously you can see for age, as patients get older, their chance of dying is higher. Their mortality for those patients is higher. it's not linear, but it could roughly be sort of approximated by a line. Many physiological values, however, are U-shaped. We live in a Goldilocks zone where high values and low values indicate some form of disturbance. And serum sodium is one that I've just picked out here just to show you the kind of relationship that can be quite easily seen when you look at this type of data. And this type of relationship can then be turned into either a score or a predicted risk of death. It doesn't necessarily mean that the sodium level is the cause of death. It means that there's an association. And say, for instance, here with the patients who've got high sodiums of 150 and above, some of those are likely to be patients either with head injuries who are having hypertonic treatment with pushing up the sodium, or have even got diabetes insipidus because of severe head injuries. But it's an association that can be used to develop a predicted risk of death, and you can combine these type of features together to give you an overall predicted risk for a patient. And obviously they're additive to a degree. So a 90-year-old with a sodium of 150 plus is going to have a higher mortality than the individual value itself. There are three concepts that are worth talking a little bit about when we're looking at scores. There's discrimination, calibration, and validation. These get spoken about in any sort of piece of literature or discussion that talks about a scoring system or illness severity score. These features are inherent in the score and inherent to have some degree of understanding of them to realize the applicability and also the limitations of the score. Discrimination describes how well a score or prediction model gives a higher score to someone who's going to die and a lower score to patients who survive. So a perfect score would give everyone who died 100% risk of death and everyone who survived a 0% risk of death. Obviously, no score is that good. Nor are we as clinicians that good at predicting these things. The discrimination is the ability to separate the two. Calibration is how well the predictions work overall, how close your predictions are to reality. And validation refers to if you develop a model, you have to then sort of test the model either in another sort of data set or have to test it in external data, and importantly, have to assess its applicability when you use that model in the context where you work or where you're going to apply that type of model. All of that is inherent in validation. Discrimination is there are a variety of different markers and measures of discrimination. The most common one is the area under the receiver operating characteristic curve, which is a plot of the 1 minus the specificity against sensitivity. And if you had a Toyn cost, you get a line as you see here. If the area under that line then gives you the area under the receiver operating characteristic, and the greater that area, the more discriminatory the score is. So an example of a very highly discriminatory score is the classic score for burns. So when I was an anaesthetic SHO working in London in the 1990s, and working briefly in a burns unit, the mantra that was said then was that if you add the percentage burn to the age, you get the expected mortality of the patient. As I moved to Australia and went to work in a burns unit, more formally working in the ICU, it sort of didn't quite seem to be right. However, that score, adding the age to the percentage risk of to the percentage area burn, is highly discriminatory. People that die are typically older. People that die from burns have high percentage area burns. It does not mean, though, that despite that very good discrimination, and the discrimination for just those two figures comes up at about 0.9. I mean, that's really good. It doesn't mean that if you're a 50-year-old man with a 50% burn, you've got 100% mortality. So one of the pieces of work that I was involved in more than 10 years ago now was to validate that score and apply additional information such as the Apache score to these patients to see what the true mortality was. And we validated this score and improved it further by adding in the Apache score and components of the Apache score. So actually the mortality in Australia for a 50-year-old man with a 50% burn is 40%. So it's not 100% at all. It's very discriminatory though. People that die have greater percentage burns. The other thing that was important for us when we did this validation is that we realized that for a man it's 40%, but for a woman it's 60%. So taking this score and applying it to our cohort, and this wasn't just the cohort within the hospital where I work, this was applying it to all the burns units across Australia and New Zealand, and there was a consistent message coming through that women were more likely to die with burns for the same percentage burn area. That validation process showed us that we needed to have better mortality prediction for this patient cohort. So that's the example of discrimination, calibration, and validation. So the overall purpose of severity of illness scores and mortality prediction models is primarily to sort of as a quality of care evaluation and audit. So severity scoring systems allow you to appropriately interpret and compare mortality outcomes of patient cohorts and ICUs. Patient cohorts can be geographical cohorts, they can be diagnostic cohorts, they can be time epoch cohorts, eras. It allows you to interpret resource and inform resource allocation and management. And although I'm not going to really sort of cover it very much in this talk, it also allows you to have comparison of how well matched groups are in interventional trials. We've recently completed a trial of oxygen administration in patients undergoing ECMO, and the Apache scores and SOFA scores in the two groups that were randomized were exactly the same. So we're really pleased about the randomization. When we are using severity scores for benchmarking, perhaps the single most important metric that they use to create is a metric that's well known. It's the standardized mortality ratio that divides the observed number of deaths for that cohort, that ICU, that epoch, by the predicted number of deaths. This allows you then to interpret the outcomes for those cohorts in the context of knowing whether there are more or less deaths than predicted. So if the SMR is greater than 1, you have more deaths than predicted. If it's less than 1, you've got less deaths than predicted. It also allows you to say, for a standard patient, and a 65-year-old man weighing 83 kilos, 174 centimeters, admitted with sepsis, that is that other than young people with overdoses who end up in ICU, our ICUs, unfortunately, too commonly, this is the most common severely ill medical patient that comes through Australian and New Zealand ICUs. There is variation in how likely that patient is to survive, depending on which ICU they go to. Now, some of that is variation that's due down to the practices that happen in the ICU. Some of that is due to systems that exist that mean that you can't treat a patient the same in the middle of Australia as you can in a large hospital in Melbourne or Sydney. But the standardized mortality ratio is the one that allows us to do it, and we can't calculate the predicted number of deaths without knowing the predicted mortality for each patient. So what I've done here is give you a bit of a sort of time series, a bit of a story of what's happened to us in Australia and New Zealand. So if you go back to the 2000s, early 2000s, the mortality in Australian and New Zealand ICUs was around about 15%. And in the early 2000s, for a variety of different reasons, mortality started dropping. At that time, the observed mortality, which are the sort of open circles, was not far off the predicted mortality that was calculated by the Apache 3 scoring system. It was a little bit less, but you can see over the first few years in the 2000s, the observed mortality, the white dots, progressively went down. Now, some of that is due to improvements in practice. Some of that is actually due to increased capacity, ICU capacity, that allowed more patients to be brought into ICU and actually less severely ill patients to come into the ICU. So you can see that the predicted mortality also went down in parallel. As time went on over the next few years, observed mortality declined further. Predicted mortality relatively plateaued, but the two started to deviate further. And as we come into the last decade and the sort of 2010s, you can see that there's a progressive decline in observed mortality, and predicted mortality starts to decline as well. But the predicted mortality from Apache 3 was much higher than the observed mortality. This is a loss of calibration of the model. The model is over predicting. The mortality prediction models is giving us a higher predicted mortality than is actually occurring in the ICUs. That wouldn't be too much of a problem if it was the same for every patient. Unfortunately, it wasn't. What we could see at the time was that they were different. Apache over-predicted mortality for everyone, except it over-predicted a lot for certain groups and less for others. So if you were a hospital that did lots of valvular heart surgery or lots of orthopedic surgery that came through your ICU, because the predictions were so far off and so much higher than the true mortality, those ICUs would tend to have lower SMRs and look to have better outcomes than the contemporary ICUs who had a different case mix. That resulted, this is actually a funnel plot of SMRs from Australia, from the main metropolitan tertiary ICUs that was reporting to the registry in 2012. And you can see most of the SMRs are centered around 0.7 because the SMR is lower than 1, because our predictions, our observed mortality is lower than predicted. And I've highlighted 2 hospitals. When we then introduced our own version of Apache, our own risk model, everyone came back to 1, so our predictions were accurate. And some hospitals that looked to have acceptable SMRs swapped with hospitals that appear to have higher mortality than predicted, once we took into account that variation in case mix. So this is an example of needing to have a well-calibrated and discriminatory model that is validated in the cohort of patients that you've got. And the way in which we did this is we did it with sort of almost 500,000 ICU admissions. For comparison, Apache 2 and Apache 3 were developed on much smaller cohorts. Apache 4 was developed on about 150,000 patients. So we had the luxury of having a much bigger cohort, and we could add in additional diagnoses, add in new variables such as chronic illnesses from multiple different scores, treatment limitations, ventilation, lead time, a variety of different things, and create different equations for different diagnostic groups. So the version that we have now essentially has a different equation for every diagnostic group. What it means is that different components get weighted differently. The GCS is much more important in a neurosurgical or neurological diagnosis than it is for a post-op cardiothoracic patient, for instance, where if the GCS is written at 3, it's more likely that it's a data entry error. The other thing that it's allowed us to do is to see the relative importance of the different components. So this is the relative importance, the relative impact, should we say, of the different components that go into making up as individuals' predicted risk of death. One of the things that surprised me was that the diagnosis and the age are about equivalent in that they both contribute about 15% to the overall predictive capacity of these scores. How acutely sick the patient is accounts for about 1/3 of it overall. So your acute physiology and your acute biochemical values account for 35-40% of the overall predictive capacity. And then all the other things are much smaller: your elective surgical cases, source of admission, chronic health variables, much less important, still important, and treatment limitations on admission to ICU still important, but not so much as the other variables. And we went from having predictions that were much higher than the observed mortality for medical, neurosurgical, surgical, cardiothoracic patients to having predictions that were much closer to reality. We introduced our own prediction model in 2014-15, based on data from the couple of years before, and you can see the overall predictions were much closer to observed mortality. And then over the next few years, observed mortality continued to decline. The predicted mortality sort of stayed about the same. Now, that's reassuring in some ways, because it's possibly telling us that we're actually getting better in our practice overall. It does, however, mean that if we want to make sure that this model remains valid and is equally applicable to all different patients, we'll probably have to reset it. So just before the COVID pandemic occurred, we re-examined the prediction models and reset it and introduced it in sort of mid-2020, just as the COVID pandemic was starting to affect particularly sort of Italy, Northern Europe and America, and then spreading out around the rest of the world, and through to you guys in your part of the world shortly afterwards as well. And what we found was that the predictions were remarkably good. And for us in Australia, COVID didn't affect us very severely in 2020. We had a much bigger effect in 2021. And we saw the impact of that go through into 2022. And you can see that the predicted mortality goes up and the observed mortality goes up and goes closer to it. And surprisingly, the predictions were really quite accurate for COVID patients themselves. But we could see there was an overall system effect from the COVID pandemic that we're just starting to come out of now. So there are some pitfalls and some controversies to think about when we're thinking about mortality prediction in critical care. The first one is to consider sort of individuals and cohorts. I've had many people come to me, or I've worked with over the time, who said, wouldn't it be great if we had a mortality prediction model that's going to tell us whether the person is going to die or survive, so that we know whether to admit them to ICU. I actually think this is probably one of the dangers of these type of models. I don't think they should be used in that sort of way. A mortality prediction model for ICU patients should be used to look at the overall survival outcomes of the cohorts of patients. They don't work as well when you apply them to a single individual. They work pretty well when you apply them to cohorts, particularly if they've been developed in a sort of accurate way. If you do apply them to individuals, you also run the risk of actually making them paradoxically less useful. So say if someone said to me, oh, this patient has a 90% risk of death, my temptation would be to not admit that patient to the ICU. If I and my colleagues then followed that for every patient that had a 90% risk of death, and that means that 1 in 10 of those patients, they survive, we would be more likely to not admit them to the ICU. Therefore, the majority of them, or probably all of them, would die, and you turn a 90% risk into 100% risk. That's because it's a model that's been developed on ICU patients to predict the mortality of patients who are in the ICU. That type of model shouldn't be applied to whether you should admit someone to ICU. You can use a score or a model to actually identify patients at greater risk and intervene on them, but yet we have to be careful about applying them in a way that then actually makes it difficult to either interpret the model or even potentially lead to disadvantaging the patients. The other thing is that however these type of mortality prediction models are are developed, the impact of missingness and bias in the model can have a big effect on the conclusions that you draw from its use. In Australia, there is a very strong signal that comes through in our data that the more remote you are, the further the distance from a metropolitan centre that the patient lives, the more likely that patient is to survive. Not to die, to survive. That makes no sense. There is no honest reason why that can be true. The reason why that appears to be true in the data set is because of the impact of patients that are missing from the data set. If you are critically ill and collapse on the road outside the big tertiary hospital where I live, someone picks you up, delivers you to the ICU, to the 60-bed ICU where I work, and that person turns up in the data set. If you live in the centre of Australia, where your nearest hospital is Alice Springs Hospital, which has to service an area approximately the same geographical land area as the combination of Afghanistan and Pakistan together, that person dies before they can turn up in the actual data set, or dies before they can even turn up at primary healthcare. So that biases the data set to make patients who have survived to arrive in the data set appear to have more survivors, but it's actually because there are patients missing from the data. So that kind of information is important to take into account. Another aspect of this is actual bias in the data itself. So I put this example here because it's a really well-known example. It's not a medical example, but it's such a clear example of bias in the data driving perverse practice that it's one of my favorites. So ProPublica in nearly, well, it's 8 years ago now, published a story about an algorithm that was being used by judicial services in Florida, which estimated the likelihood of a person who's appearing in the court of them reoffending. And it allocated Black individuals a higher risk of reoffending than white individuals. That led to different sentencing and different sort of the way in which these people were dealt with in the judicial system. It was differed based on the prediction model that they were using. That was an inherently biased model. What it was doing, it was data telling you what you do, not data telling you what you should do. And where it was also an example of using a model to drive your practice, not necessarily using a prediction model to compare how your practice differs from the predictions that come up from the model. But it's a very well-known example of bias in data, and bias particularly when it comes to culturally diverse ethnic groups. That kind of bias, if it's present in the data set, particularly if you include that type of information into your models, can actually end up with perverse behaviors because it drives your practice to match what was already there, not to drive change from the practices that were represented in the data set. And then the last comment on sort of pitfalls and controversies is really about timing. So timing for intensive care models. If you have intensive care models that are calculated when a person comes into ICU, that's great for comparing ICUs. If you want to look at how well surgery has been performed, the ideal is to have a model that takes only data from prior to the surgery. Some of the original versions of the possum model actually took data after the surgery. So if there's poor surgical practice and a patient comes out of surgery with physiological derangement, that will make your score look higher. Your chance of death is higher. If you're using that score, however, to compare the quality of the perioperative process, the quality of the surgical process, you have to take data from before that surgery occurred. That's why intensive care models are great for comparing intensive care outcomes. They may not be the perfect thing for looking at purely surgical outcomes. The other thing is, and I've sort of alluded to it before, things change over time. So if you look at how we compare over time, it's good to have a model that allows you, that has been calibrated to a particular time point, because you can look back and say, oh, it looks like we really are getting better. But it's also, you also may need to have something that represents contemporary practice. There are models that build in a time component into the model and assume that the pattern that you saw over the previous years will continue over the subsequent years. The sort of reductio ad absurdum development of this would be, though, to continue this prediction down. And if we'd done this on the Australian and New Zealand data from the first decade of the 2000s, we would have zero mortality. It would predict zero mortality in the ICUs by 2030, which obviously is nonsense. But on that thought, then what about the future of prediction in ICU? Although I raise caveats about applying mortality predictions to individual patients, individualized predictions are absolutely becoming part of routine practice. Companies such as Cerner and Philips and Epic build scoring systems into their EMRs that allow you to identify higher or lower risk patients. Individualized predictions of outcome can stratify patients to more intense or less intense therapy groups. Individualized predictions are coming. And will become a greater part of what we do. However, it's important to remember the warnings is probably perhaps a too harsh a word to use, but to remember the pros and cons of the model, of the information that's gone into these type of models, to interpret whether it's appropriate to use them in this type of way, and applying them to something that the model wasn't developed for, or a patient cohort that it wasn't developed on, is something that should be avoided. The other thing is, the next thing is that, if I can move my slides forward, a little bit, yeah, is mortality prediction model is expanding out, and there are new prediction models for lots of different things. In particular, length of stay in ICU is one that I'm seeing increasingly used. Also seeing mortality prediction models being developed in many other parts of the world. I was reading the paper last night from Rwanda, which had developed a version of the MPM model. The Dutch, the UK, the Brazilians, the Colombians, the Uruguayans all have models that predict length of stay. Predicting length of stay is something that requires a degree of sophistication to it. It's a bit more complex. And it's a bit more complex primarily because of this, because the sicker the patients are, the longer they tend to stay in ICU, up until the point when you get to when they're really sick, when length of stay drops a bit, because patients die before they can spend long enough to survive in the ICU. But we've recently been sort of developing these and have put them into practice, and so ICUs can compare how they work, and they work generally well for the majority of conditions. So, and I've just picked out a few here just as an example. So for AAAs, cardiac surgery, GI surgery, spinal surgery, the observed length of stay there in hours is pretty close to the predicted length of stay. So it's not bad if you want to say you're to an ICU, or to say to a hospital, look, your intensive care length of stay is either longer or shorter than predicted. It's not bad for ventilated and not ventilated patients. Where they fail, though, and this is an example of where another example of why it's good to check the validity of the model in a variety of different cohorts, is in patients who are having sort of more intensive ICU therapies, such as renal replacement or ECMO. The predictions fall way short of the actual true length of stay of the patients. We're at present actually embarking on some comparisons with the Brazilians, who have very similar mortality prediction, but very different lengths of stay in their ICU. But we're going to try a similar model working between the two. And then to sort of round up, really, it's a mention about machine learning and artificial intelligence. Artificial intelligence is everywhere. Now you hear about it being spoken about all the time. So the techniques used for machine learning are really quite readily available. The artificial intelligence large language models are slightly different sort of things. I'm not going to tackle those. But machine learning models are quite it's not difficult for anyone who's got some degree of data science background to run machine learning models now. And we've we've been using them to look at outcomes in cardiac arrest patients. We've already got pretty good prediction. So if we went back to Apache 3 and these sort of figures are another way of showing discrimination. So the horizontal axis is the predicted probability of death. So the green are people that survive, the red are people that die. So the green should be all over to the left and the red should be all over to the right. So the more separated they are, the better the discrimination of that prediction it is. And you can see Apache has got a bit more red stuff over to the right because they overestimate the number of deaths. In our own prediction model that predicts a higher number of sort of survivors. You can do statistical techniques to increase the separation. You can do things like decision trees and random forests to increase the separation further. And then you can bring in sort of true machine learning techniques, like things that are called gradient boosting, support vectors, and neural networks. And I'm not going to go into detail about any of these primarily because I only have a very superficial understanding of them, other than to say that you get greater separation, and the discrimination that you get with these type of models tends to be a bit better than through classical statistical techniques. However, one of the real advantages of the machine learning models is that you can combine different techniques together. So the computer can recognize that this cohort of characteristics, this age, this sex, this sodium level, this pH in this diagnosis is best predicted by a neural network, and in a different group of patients is best predicted by a gradient boosting machine, and it combines those together to get better prediction. Having said that, our routine mortality prediction is already so good that it provides a little increase, but not a huge increase. And that's, I think, why we're yet to see them really go full time. They are starting to come in, and they're definitely going to be part and parcel of prediction models for critical care in the near future. So really, in summary, I'm sort of finishing up. My aim was to show you some of the applicability and uses of prediction models for critical care, to demonstrate the concepts of discrimination, calibration, and validation without going into any of the maths behind it, talk about some of the limitations, uses, and controversies of the prediction models, and talk a little bit about the future of mortality prediction for critical care. Thank you very much indeed, and I'm happy to take any questions. Stop sharing.
Thank you so much, Dr. David. It was such a nice and eye-opening kind of a topic, because we do have many speakers or many physicians who work in critical care, but working on different kinds of model is, very less participants and very few people, they know about these different kind of prediction models. So which kind of a model do you exactly practice in your ICUs in Australia? And what exactly is the challenge which you have faced so far? One most common challenge which you might have or you overcome while applying it.
Yeah, the primary model that we use is something called the ANSROD, Australian and New Zealand Risk of Death Model. And what it is that model that we introduced in the sort of about 2015 to compare the ICUs. It gives good prediction. It's highly accurate for Australian and New Zealand intensive cares. What it is a derivation of Apache. So it takes the components of Apache and adds in some additional things. It's too complex to write down on a piece of paper. It's thousands of lines of code. So what we ask ICUs to do is to collect the basic information. So for every patient, they collect the age, diagnosis, sex, basic physiological variables, pulse, heart rate, etc. And we ask them to submit the highest and lowest values for the first 24 hours to us, along with relevant biochemical data and some chronic comorbidity data as well. And then that gets filled in for every single patient, and is very similar to the it's a very similar sort of process to the registry process that you have with the Critical Care Asia Africa Registry Price that is been up and running for a number of years in Pakistan, and IRIS in India, and other countries around your part of the world, and where those individual variables then go into a computer, and the computer then calculates the risk of death for that patient and then can sum up those risk of deaths. The kind of challenges that we get are the practical ones, where people say, I haven't got enough time to collect the data, it's too hard. So we try and keep it as simple as possible. We allow a degree of missingness in the data. We also build in validation rules so that you can't put in information about a pregnant man, for instance. Those type of things. But the typical problems that we see in it are, and we watch out for them, are the GCS, the Glasgow Coma Score, being incorrectly coded, particularly for elective surgical cases, and other things like the urine output. The ones that really matter is the GCS, because that one was really, really important. If people make a bit of an error on the sodium level, to be honest, they cancel each other out. If someone writes at 139 but it's 140, that doesn't make that much difference. So we watch for those type of things, but the burden of data collection is definitely the most difficult thing that we have. We make sure that all the reports and the data is really readily available to every ICU, so every ICU can see their data as soon as they submit it and can see the comparisons to everyone else's ICU. But those are the kind of problems that we run into, and then there's a bit of work to recalibrate it from time to time. But the actual stats behind it are quite easy.
Right. We do understand, as you talked about the Paris registry, which some of the hospitals are like following. But the main problem while applying such kind of data in Pakistan, to my assumption, is that most of the other hospitals, like those far-fetched hospitals where they have critical care, but they don't have those latest services available, they might have difficulty in not only gathering the data but obviously having having them electronically, the exact numbers and also the prediction. So we also have one question, in fact two questions. One is, how can we assess the quality and reliability of a model, number one? And then there is another question, that Video Health, for the first time we are able to start a registry. May I know how we can know about the reliability of the collected data, because people are usually reluctant in filling the data forms? Again, the same problem which you might have encountered.
Yeah, look, and we've had the same problems in Australia. We're just lucky because we're probably a few years further down the track. So we still have to deal with this type of issue. So at one end of the spectrum, we've got the ICU where I work that's got an electronic medical record, that's got a system that extracts data. You've got a person paid to collect the data. We have the luxury of having everything work reasonably well. I mean, we could probably do with 2 data collectors, but because we have 3,000 admissions a year, 3,500 admissions a year, but we have that type of level. But we also have to cater for the other type of levels, such as the small ICU in a regional area that has to collect everything on paper and has a small 3-bedded ICU that only has a medical doctor there sort of 3 days of the week. So there is really quite a big spectrum. The way in which we try and deal with that is to try and make it as easy as possible, and accept the fact that things aren't perfect when you start off, and the kind of things that people worry about, the burden of data collection, but they also worry about people being able to see the outcomes of their patients when they're concerned that they might get interpreted as poorly performing. Actually, it's well recognized that when you start collecting data, the data won't be perfect. So we know that. We also know that that things improve over time, and usually sites come on, they improve the data collection quite quickly, and you can start to interpret information quite quickly. And plus, they see the value of having a system, because we've got basically a fairly simple system that people put the data into. And as soon as you put it in fact, anyone who's got a mobile phone now can just tap in the numbers. They can see a comparison of how many patients they've had that week. And nearly everyone is collecting it on a spreadsheet somewhere anyway these days. I was recently in Papua New Guinea, and they have many less resources than Pakistan and India and South Asia does, and they're just using a spreadsheet or a Google Doc to enter the data. And if they put it into the registry system, the only thing that does is aggregate it for them, and they get automatic reports. So we're providing that, trying to help them with providing that sort of service. So it's about trying to make it easy and see the value of the data it is, but also recognizing that it's never perfect at the beginning, and there's a learning curve.
That's right. Let me check if we have some more questions for you. So we have Suhair Khan who is asking, have you noted a drift in your predictive model post-pandemic? Does the data present any change in predicting mortality for the patients infected with different phenotypes of COVID-19? That's quite a good question, actually.
Yeah, good question. We There's so, and actually, this goes partly back to one of the previous questions that I didn't fully answer about how you assess calibration and the performance of the model, because we have looked at that in the COVID patients. What we don't have is really good data on the different strain of COVID. We do know the predominant strain as the different waves came through, and for us it was Delta, then Omicron, which really affected us. We didn't get much of the others. And purely by chance, the predictions actually worked pretty well for the COVID patients until we got overwhelmed with COVID. And it was only really Melbourne and Sydney that got overwhelmed. And as the ICUs got full, the mortality went up progressively, and progressively higher than the predicted mortality. But we think it wasn't so much due to the actual strain of COVID. What it was due to was the actual strain on the ICU. So strain in a different sense, causing lack of resources. So, for instance, our ICU went from a sort of 50-bed ICU to sort of 75 to 80 beds, and with 20 patients on ECMO at one point. So you can't provide normal care in that sort of situation, and we didn't have enough nurses to do it. And that's a similar sort of experience that I'm sure many people had in their ICUs in slightly different ways. And that was the strain that we saw, not the strain of not variation with the different strains of COVID. As strain on the system reduced, the observed mortality came back close to predicted. And we could see that by just actually measuring the calibration statistically, and just looking at how close our observed mortality were to the predicted mortality from the COVID patients. And at the moment, it's still pretty predictive, surprisingly. I mean, I think that's just luck. We just ended up with it like that. What we have seen, though, is that we can differentiate a patient who's admitted with true COVID pneumonitis from a patient who has asthma that's been exacerbated with COVID, to someone who has got a trauma admission or an overdose, or who has an incidental finding of COVID. And what we can see is in those patients, it underpredicts mortality. And what's happening is that COVID is pushing up the mortality in those incidental infections. We're not seeing that reflected in the actual prediction model itself. So the answer is a bit complex, but it's the different, we weren't able to detect the different strains. It was straight on the system for us.
That's right. Thank you. So actually, what I'm understanding from what you have just told us is that because COVID was it was a pandemic when it happened, and different. Actually, we all saw different kind of strains in COVID. So same goes for the other kind of infections as well in the ICU, where the patient gets admitted with different kind of infections, and then the mortality or the prediction, it can differ from what you had expected?
Yes, we think so. We've been seeing that. I mean, the COVID pandemic put a much more sort of an effect on the resources than at any time, but we can see from the data that we've got that when ICUs get busy, or when an individual ICU gets busy or has staffing problems or grows very rapidly and doesn't employ enough staff to look after the patients, then usually the mortality outcomes deteriorate. And we actually pick that up from the funnel plots from an ICU having a higher mortality than predicted. And when that occurs, we look into the additional data for that ICU and provide them a report so that they can then sort of take that away. But it has never been as dramatic as it was during the COVID pandemic, but it definitely occurs during the rest of the time. And our ICUs are almost exclusively post ICUs.
Mm-hmm. So we have got another very interesting question. That's by Kamal Afridi that he's asking, can you please comment on what type of ICU you have at Australia and New Zealand, and open or closed ICU one, or the intensive, is it the intensivist who's taking care of the patients, or the anesthesiologist, or is it the multidisciplinary departments who take care of the patients?
They're essentially closed ICUs, other than in the tiny small rural ICUs where you may have a anaesthetist or a physician who's got an interest in ICU that will be running it. But essentially, the ICU department functions as its own ICU. We work very closely with anesthetics, but all of the the majority, about a third of intensivists are from physician backgrounds, a third from anesthetic background, and then the remainder from a mixture of surgical and predominantly emergency background and pure ICU background. But we work as a sort of multidisciplinary group, but where the intensivist is the primary coordinating person in charge of the care in the ICU. It always has to be very sort of, it has to be collaborative. It has to work as a team. It's very much a team organization. But the kind of procedures, the kind of processes that you would expect an intensive care specialist to do in an Australian ICU would be the same no matter what background they come from. So officially, I'm from a physician background, but tomorrow I've got to put a double lumen tube into a patient for a variety of different procedures. The skill set is in theory the same, but people will bring their own sort of variety of their own interest to it. But essentially, they're closed ICUs where the intensive care runs the ICU. So we'll do the intubations, ECMO cannulations. The nurses will run all the aspects of the renal replacement therapy. So it's very much a combined, but closed sort of pure intensive care specialty is what it is.
Thank you so very much, Dr. David. Let me check the chat box. I think we don't have any more messages over there for you. We are really grateful that you took time out at the midnight. In the meanwhile, I would also like to ask my participants to kindly fill in the feedback form so that we can send you the e-certificate. And also a very happy Ramadan Mubarak to everyone out there, and even to you, to Dr. David. It's our holy month coming right up. For 1 month, you might be knowing it. So I would also want to ask that should we continue the same timing, because it's the prayer time. That's why you can't see many people right now over here who would have been love to ask questions to you. But should we change the timings, or would you guys like to continue with the same timings? So please let us know in the feedback when you give the feedback form. And I'm really grateful to you again. We would definitely have you on board in our coming session on ICU, and hope to see you again soon. Thank you so very much, Dr. David, from the bottom of my heart. Thank you.
Thank you very much indeed for the opportunity. Looking forward to catching up with you guys again sometime soon.
All right. Thank you. Have a nice night. Have a good night.
Thank you. See you later.
Okay. Take care. Bye.